remember the collimator? This is actually the treatment part of it. This is what does the cone beam CT. So this is an X-ray head. This is an imaging cassette. And this part here is the imaging cassette for the MV imager. So this is a KV imager, X-ray. This is an MV imager. Oh, sorry. And this is an Elekta linear accelerator, same thing, does exactly the same thing, it's just made by a different manufacturer. Elekta is part of Philips. And Philips, of course, is Dutch owned, but it's multinational, same as Varian, they're multinational. So it really does depend on what the department likes.
Do you have a preference?
I have a preference for Varian, simply because I've worked on Varian a lot longer than I ever worked on Elekta. So it depends. There used to be a third one, which is Siemens, but they've stopped making linear accelerators. There is still a couple of Siemens machines floating around the area.
Do they make them all in California?
What?
Do they make them all in
No,
California?
no.
Oh, okay.
The Varian machine is all made in California.
Uh-huh.
The Elektas and the Siemens are made in various other places.
Okay.
Anybody can manufacture this?
Pardon?
Anybody can manufacture this if they have like a.
If you have enough money and the technical background, and the problem is that Varian and Elekta to a certain extent and Siemens are the leaders in their field. So it would take a lot to overcome that, yeah. And nobody, because these machines are used to treat patients, safety is paramount. And the fact that you're a new up-and-coming person or field, it takes a lot to get into this field as far as the manufacturers go. So, the next thing is VIRT, which is actually over there. It's a virtual reality system, which we got, has anybody heard of Perkins grants? Perkins is a company that gives grants to schools, whether it's colleges, universities, or high schools. And thanks to Perkins grant, we were able to order a VIRT system, virtual reality system. It is a linear accelerator. You saw the Varian machine. What you will see in the virtual reality machine looks exactly like that. It will do everything an actual machine will do, except actually produce radiation because it's a virtual reality. But, and we'll start in a little bit, not today, probably not next week, week after perhaps, start actually getting you on the system. The good thing about the Varian machine is that, or the virtual reality machine, is that it comes with hand controls, which are real world hand controls. So if you can control the virtual reality machine with a hand control, you can actually control a real life. That's our ideal. Oh, let's see if I can do this. No. Oh, there it goes. Okay, so this tends to be a bit loud, so bear with me.
VIRT is the flight simulator for LINACs. It offers a 3D life-size visualization of a LINAC treatment room. VIRT provides a safe, non-pressured learning environment without risk to patients or equipment. VERT is an effective solution to train student therapists. It engages learners, enhances visualization, and increases understanding of complex theoretical concepts and techniques. VERT offers a platform for continuing education, including education for nurses, radiation oncologists, and dosimetrists. VERT is not simply for students, but is also an exceptional tool for patient information. Use the real-world handheld controller to enhance the training experience, increase confidence, and build essential psychomotor skills. Everything you can do with a LINAC, you can do with VERT, except there is no radiation. VERT bridges the gap between theory and practice, and brings the LINAC into the classroom. VERT is DICOM compatible, and users can import any plan from the treatment planning system. Train with your own DICOM plans to demonstrate local techniques and explain the fundamentals of treatment planning. Beam delivery for IMRT, rapid ARC, and conformal therapy are all possible. See and hear the MLC leaves move in the beam's eye view. Look inside the patient on the LINAC couch and visualize the dose to the tumour and the avoidance of organs at risk. Anatomy knowledge plays an important role for healthcare professionals today. With imaging now paramount, upskilling staff is essential. VERT plays an integral role in the development of anatomy skills. VERT imaging tools facilitate offline training. Relational anatomy is clearly visible, and VERT is ideal to teach the concepts of isocenter, organs at risk, and beam delivery. Easily view the contours to expand cross-sectional familiarity. See the coverage of the target volume with a dose cloud, and see the change if a geographical setup error occurs. Visualize the dose delivered and review the effects of misalignment. VERT has versatile tools for dose visualization, including dose cloud, dose on CT, and dose color wash. Dose can be viewed on CT images and organs within the patient. View doses over 100% to help understand hotspots within the treatment plan. Use VERT to help teach the difficult theoretical concepts of radiotherapy whilst building understanding and awareness. Go back to the basics to build up essential and often forgotten important knowledge. Upskilling staff, introducing new techniques, and examining near-miss scenarios are just a few of the continuing education obligations for VERT. Techniques such as SABR, DIBH, and rotational techniques introduced into the clinic without adequate training can increase risk. VERT plays an important role and is a key component of a complete education package for your staff. Safely visualize mistakes or near misses. Use VERT as a plan comparison tool and incorporate into the competency assessment for new staff to prepare for recertification. VERT is radically changing the way that patients are informed about their treatment. VERT helps the patient to understand their treatment, reduces their anxiety, and allows the staff to explain the complex treatment procedure in a highly visual and engaging way, making patients partners in their treatment and increasing compliance with treatment protocols. VERT is also ideal for practicing less frequently seen departmental setups. Use the electron functionality to improve psychomotor skills and confidence with dependent controls. VERT Physics extends the capabilities of VERT to provide a comprehensive package for teaching physics and quality assurance principles. Demonstrate real-world procedures and equipment. Quality assurance models include a plotting tank, QA plate, ion chamber, calibration tank, and laser alignment tool. Teach away from the real-world LINAC initially to make the actual time on the LINAC count. VERT Physics is an effective, versatile, and engaging simulation package of physics equipment and educational content to enhance student learning. wouldn't expect a pilot to fly 747 without first training on a simulator. Vert is the flight simulator for Linux. Make a real difference to your training and educational programs with Vert.
Are those 3D glasses they're wearing?
Vert is
It
the
is.
flight simulator for
Oops,
Linux.
sorry. It is. And I have those, however, with COVID, we'll probably not use them for a little while because we'd have to, pardon? Yeah, so what we'll do is they have to be specially ordered for, I mean, we can try them.
Are they not
But-
easy to clean, like for each of us to clean?
They're not easy to clean
Oh,
because you
okay.
have to use special stuff to
I
clean
see.
them. That's why I've been avoiding using them with the other groups, so. I will, contact the, manufacturer and see what we need to do to clean them. Radiation therapy. I just looked at these, all yesterday and, we'll see what we can do here. Okay. Okay.
This is the checkers game where grandson and granddad
Oh,
will
boy. Oh, wrong one,
To the right.
Bottom right
bottom right.
of the video.
There you go.
Thank you.
I really didn't know a lot about radiation other than like X-rays.
I had no knowledge of what it was gonna be like.
My fear was just the fear of unknown. I didn't really know what to expect.
The fact that you're finally gonna take care of that cancer and get rid of it, that's the biggest relief.
Good health is on the other side.
Did everybody hear that okay?
Mhm.
Okay.
Radiation oncology is a crucial part of cancer therapy. Close to 60% of cancer patients receive radiation therapy sometime during their illness. Many times, this is with curative intent. That is, our goal is to get rid of the cancer permanently. For patients who can't be cured, radiation therapy can relieve pain and other forms of suffering and greatly improve quality of life. This is a very effective, life-saving, and life-improving therapy. Radiation kills the cancer cell by damaging its DNA. The DNA is the genetic material, the blueprint of the cell. And by damaging that material, the cell can't divide, it can't grow, and the cancer dies. Cancer cells do not repair the damage that radiation causes, as well as normal cells.
All right, Kelly, here we go. Everything looks real good.
So each time we give a radiation treatment, we destroy the cancer and damage the normal tissue a little bit, but less than we damage the cancer.
Radiation differs from chemotherapy because chemotherapy is a type of cancer killing agent that goes through the entire system and touches every part of the body. Radiation therapy and chemotherapy are often used together. Separately, they have a certain amount of effect on the tumor, but when you combine them, they very often have what they call a synergistic effect. The chemotherapy a lot of times will sensitize the tumor to the radiation therapy, and we found over the years in doing studies that we have a better response with certain tumors when the two are combined together.
One of the most enormous advances during the last 10 to 15 years has been how accurately we can target radiation therapy. Radiation therapy involves typically multiple beams, at least 2, often 3, 4, or even more beams, all of which come in from different angles, all of which hit the tumor. So the tumor sees all the beams, but the normal tissues only typically see 1 or maybe 2 beams. And by targeting these beams to within millimeter accuracy, we can destroy the tumor and leave the normal tissue almost unharmed.
Thanks. Think it's good for you?
What the hell?
Think again.
Just
Bottom
an ad.
right, the video.
Yeah.
Once we've decided that radiation therapy is going to be the treatment of choice, the first thing we need to know is the precise anatomical location of the targets that we need to treat and the normal tissues that we need to avoid. Generally, this will start with CT scan or some similar imaging technique, and this is the portion of the treatment that we call simulation. We acquire three-dimensional imaging information of the patient. And within that 3D image data set, we can localize the target, we can localize the normal tissues that we would like to avoid.
At the time of simulation, we're getting that first snapshot of the patient, and we're going to build our treatment plan around that information. And so we want to try to make sure the patient's comfortable, but also in a position that can be reproduced every day for the course of therapy.
For almost all patients, we'll make a device, we call it an immobilization device, that will hold the patient in the same position for each treatment. That way we can be sure that through 20 or 30 or even 40 treatments, we treat the exact same part of the body.
Each patient is given a set of tattoos. These are teeny tiny marks that we helped use to align them with our lasers.
The therapists are very, very good. They know how to position the patient. So the patient is in the same position every day, but also they have some comfort there with the immobilization devices.
It's critical for the patients to relax at the time of simulation and be as comfortable as possible, because that position is going to be used for several weeks of treatment. So if they're as relaxed as possible, that helps us get good positioning information, and that will make it easier for them throughout the course of treatment. After the images are taken and the patient has been marked and is released, in fact, that's where the real treatment planning work begins.
The images are transmitted to dosimetry. Dosimetry is the area of radiation oncology where we do our treatment planning. The radiation oncologist will, in conjunction with the dosimetrist, pinpoint the tumor by looking at all the images that we just got in simulation. Once we have the tumor pinpointed, and if there are lymph nodes that need to be involved as well, we pinpoint those, we mark those out, and the dosimetrist then will start to work on arranging the beams so we can get the best plan for the patient, which will have the least amount of side effects and the highest chance for cure.
Generally speaking, this meticulous planning process happens behind the scenes, and the patient is never aware of this.
So what we're looking at today is a patient with a primary tumor of the larynx. So once we have the information from the imaging studies, we create a full three-dimensional reconstruction of the patient. From that, then you can actually look at it from any angle and view what the tumor shape, its location, its relationship to the normal tissues. So we're looking at axial slice through the patient's neck. This is just above the shoulders. Circles have been drawn by the physician to define areas that need to be treated. Each of them represents a different level of risk and therefore a different associated dose, which the physician will prescribe to the tumor.
Going every day for radiation therapy, you do feel like you are somewhat in control, that you're doing what you have to do to get through this.
So now, to me, this is a job. I got to take care of my health. Laying on that table, I think about what I need to do going forward. Actually killing a cancer cell.
Radiation therapy involves a team approach. A nurse will help with education and help to monitor for side effects. A physicist is crucial in helping to make sure our machines are delivering radiation accurately. In addition, the therapist will place the patient on the machine each day, make sure the machine is running properly at that moment, and will alert the doctor if the therapist notices that something seems untoward in the patient's course of treatment. I feel very strongly that patients should not choose a radiation oncologist based on some particular brand of machine that a radiation oncologist has. The most important part of the radiation oncologist is the doctor-patient relationship and the knowledge of how to treat cancer. All modern equipment can effectively treat cancer with a good radiation oncologist working closely with the patient.
Once we bring the patient into the treatment room, the first thing we'll do is ask each patient their name and their date of birth. That way we can verify we have the correct patient and the correct chart. As therapists, we'll lay down the patient onto the treatment table and we'll proceed with aligning the patient to our lasers
We'll typically do that by shutting the lights off and raising the table and bringing it up towards the linear accelerator.
We tell the patient to expect to be on the treatment machine itself about 15-20 minutes. Most of that is setup time, because you need to make sure that the patient's in the exact same position every single day.
The treatments are delivered by specially trained radiation therapy technologists. When patients come in, they don't always have the same therapist, but we're able to reproduce the treatments for each patient by referring to the treatment charts.
After we are all done with setting our parameters and leveling the patient, we'll tell the patient that we're going to exit the room and we'll start the process of beginning the treatment. Patients can take comfort in knowing that the radiation therapists are right outside the treatment room and that we can see and hear them at all times during their course of treatment. Families are not allowed in the radiation treatment room because they would be exposed to radiation.
You're gonna feel the table move, Kelly.
According to the treatment planning, the radiation beam may rotate around the patient to different angles during their treatment. The actual radiation beam is only on for a matter of seconds during the radiation treatment.
Knowing that the radiation is killing the cancer cells, and also just kill them, you know, you just kind of talk your way through it, and it does help, and it gives you a boost of, I can do this, I can fight this, I'm going to beat it.
During a treatment, patients don't feel a thing. They lie quietly on the table, the machine makes a buzzing sound, the treatment's over, and the patient gets up off the table.
The treatment is totally painless. I mean, I was amazed. You go through all this setup and getting in the right position and all that type of thing, and when they shut the door, it's 13 seconds later and it's over with, and you're getting out of there. The radiation itself was not a bad experience at all.
During the treatment, the patient should expect to have imaging done most likely once every 5 treatments. That imaging study will be looked at by the radiation oncologist, and it will be compared to the initial simulation to make sure that it is very, very close or exactly what it was in the beginning. Sometimes the radiation oncologist will take imaging studies more frequently if needed.
In order to assess the success of radiation treatment, we will often obtain scans sometime after the treatment is completed, and sometimes that time can be as much as 6 months after treatment is done.
The fear of the unknown and what was going to happen is the biggest fear of all, is how much it will affect your life and how you would adapt to whatever side effects you had.
Depending on the exact treatment that's given, radiation therapy can have everything from almost no effect on your quality of life to a moderate effect. This is something you need to discuss with your individual physician and will vary as to the exact course of radiation therapy that you receive.
Just gonna have you look straight at me.
During the course of radiation therapy, you will see a radiation oncologist every week, and during that time, it's crucial that you discuss with him or her whether you're having any side effects from treatment, because most side effects can be taken care of with the appropriate medication.
You may notice skin changes, like a sunburn or suntan. Not right away, but it may occur maybe during the middle or towards the end of treatment. You may notice some tiredness, some fatigue. Your blood counts may go down just a little bit, and so your doctor will check those.
Radiation therapy does not make patients radioactive. Once a treatment is done, they can go home and play with their grandchildren, hold their newborn baby without any risk to their family.
There's many patients that go through the radiation treatment and continue to work, continue up all their normal activities. In most cases, the patient can drive themselves to the radiation treatment. Patients are often concerned if they can have sexual activity during the radiation treatment, and in most cases they can, and should continue to enjoy as much of a quality of life as they can. For those patients who are having more significant side effects, they should definitely go and speak with the nurse, and then the nurse and the physician can address appropriately with the patient. Taking care of yourself during the radiation process is very, very important. Normal hygiene, nutrition, keeping yourself very well hydrated. Nutrition is absolutely important. It's going to help regenerate all those new cells. Moderate exercise is actually very good for the patient, and keeping their normal activity.
When patients are undergoing treatment, they feel like they are doing something for their cancer. Once treatment is over, sometimes they have a little bit of difficulty letting go because they feel like, now what? But what they need to be assured of is that they have gotten the complete prescribed treatment. The treatment is doing the work that it was called to do. The treatment will continue working after treatment is over, and that they will be monitored closely by their doctor.
Safeguards are taken to make sure that patients are as safe as can be. We do quality assurance checks in the morning. There are monthly checks done by physicists, quarterly annual checks done. The machine is calibrated and looked at daily.
The whole team is always focused on safety in radiation therapy. Any of the equipment that's used to care for patients or that's used to acquire the information used for treatment planning has a physicist behind the scenes ensuring the safety of that equipment. There are many different tools available to the physicist and dosimetry team in ensuring safe and quality care in radiation therapy, and that includes treatment planning systems, detectors that are used to do measurements for quality assurance. We have national standards that we follow with respect to calibration of linear accelerator to make sure that units of radiation are equivalent regardless of where you were treated.
Radiotherapy equipment is designed to be as fail-safe as possible. So what this means is that there are a tremendous number of interlocks that are in place, and there's a large amount of information that's constantly being passed from one piece of equipment to another. And if any of that information, if even one piece of information is not exactly what we expect it to be, the machine will turn itself off. If a patient notices that something is different, then they should absolutely let their providers know before treatment is initiated. Once the dose is delivered, we can't take that dose back out, so this is something that we need to know before the treatment is delivered.
I think it's very important that patients do take an active role in their treatment.
We want patients to be partners in their care. We want patients to monitor themselves, to monitor their side effects. If they sense anything that's out of the ordinary, if they have any questions, they should feel very free to bring it to their radiation oncologist's attention.
Thank you. I think it's important to recognize that radiation therapy can cure many, many patients. We probably cure over 100,000 patients a year who have cancer, with radiation alone or by combining radiation with chemotherapy. Radiation therapy plays an important role in reducing pain or making symptoms improve in patients who can't be cured. But it's also a powerful curative way of treating patients.
I have a really good feeling that the doctors and the technicians have developed an individual program that does deliver the radiation to the haven't got needed.
Have a positive attitude and just think about it as being something that you're doing for yourself, that you need to do for yourself, for your health, and stay positive.
This is the necessary treatment that I have to get rid of this cancer, and that's their goal, is it will be gone. So I show up every day with that expectation that I'm one down, one more closer to it being gone.
My hope is to retire and have a nice long life afterwards and not even think back on the cancer other than as
You've been diagnosed with early stage prostate cancer, but not despair. Compared to many other.
Any questions on that? No? Did you see the patient who was being treated with an IV, with IV running? There was one that was covered, the IV bag was covered in a brown bag. Did you see that? Did you notice that?
I did not see that.
Oh, okay.
Was that the woman on the bed?
Well, there was I can't remember whether it was a lady or a gentleman, but they had two IVs running with an IV. There was an IV pole with two IV bags and a pump, and one of them was covered in a brown plastic bag. That is because she had chemo running, and some of the chemotherapy is light sensitive. So that's why they cover it in brown plastic to keep the light off of it. The other thing that one of the therapists said, which I don't agree with, and I wish she'd never said it because I keep getting questions about it, is she said that we don't, the patient is not, pardon? No, is not usually treated by the same therapist every day. Did anybody hear that?
Yes.
That is not true. That is bull. We work in teams, as I've probably told you ad nauseum, but usually there's 2 or 3 people on the machine. We treat these patients day in, day out. If it's a large center, like this was from the University of Michigan, if it's a large center, then the therapists are swapped around every 3 months or so. So what happens then is that 2 therapists are shifted, 1 is left, and then 2 new people come in. So there's always 1 person that the therapist or that the patient knows. Or if there's only 2 people on the machine, then 1 is shifted out and 1 is shifted in. But there's always 1 person on the machine that the patient knows. And that's for 2 reasons. 1 is continuity, so the patient doesn't look at you and say, do you know what you're doing? I haven't seen you before. And they do, they actually say that. And 2, for radiation safety, because if it's a weird or difficult setup, then the therapist who is staying knows the idiosyncrasies of the positioning. So that's basically why it is. But it's mainly for patient comfort, is that, you know, you come in and the patient looks at you and says, I don't know you. Yeah. Exactly. And it makes the patient feel comfortable. Think about radioactivity. Radioactive. No patient that is treated with external beam radiation therapy is radioactive. They do not glow in the dark. Much as a lot of patients will still say that, usually in a joking fashion because they know better. They'll say, well, you know, I glow in the dark now. But in all seriousness, no. Nobody who is treated with external beam is radioactive. That is different from brachytherapy, in which, yes, you may be. But external beam, as you saw it there, nobody is radioactive. You can go home, and as it says in the movie, as it says in the video, you can play with your kids, you can play with your grandkids, you can do anything that you want. You can work, you can go to school, whatever it happens to be. Okay? Okay, so, to get back to this stuff. Part of our, has anybody ever heard of universal precautions? We'll be dealing with this later on in patient care. What is universal precautions?
Washing your hands.
Precautions taken.
You mean like what is the definition?
What is universal? Describe to me what I mean by universal precautions.
Like the same set of health standards across all
Yeah,
hospitals?
okay. So basically universal precautions is treating everyone as if they had a communicable disease. And part of that is certainly washing your hands. Part of that is wearing gloves. What we're going to do today is show you the correct way to take off gloves. Putting them on is fine. These are not sterile gloves. These are gloves that we would use in the department every day to treat patients. So, I put the gloves on. These are medium, so they should fit most people, with the possible exception, I'm sorry. I don't have any large
I'll
ones.
squeeze them for them. We'll make it work.
Okay, no, these are quite good. So, gloves. I want you to
Oh, it shocked me.
put some,
You're supposed to shake it?
doesn't matter if you shake them or not, okay. Put some cream on my hands.
How much? A lot or little?
Keep going. That's fine, that's fine. Thank you. So, the idea is my hands are soiled. How do I get them off without covering my hands in shaving cream?
Pull it.
Pinch at the wrist.
Pinch it and pull it out, yeah.
Mhm.
And then.
So I do that,
Yes. And then you do it.
and then I do it this way. And I should be able to, shoot. I should be able to.
You got a whole bunch of it though.
Yeah, there was so much in there, yeah, okay. So that's why we're going to practice taking off and putting on gloves. I won't put an awful lot on anybody.
I know how to do
Okay.
this. I did this for 2 years.
So, couple of gloves. So sterile ones are something else. Where's the, here we go. I won't put an awful lot on.
Oh, we could
Yeah,
put
put
one
them
at a
on,
time?
put them on. You might want to just roll up your sleeves just a tad.
Yeah, sorry, he's on
I have really manly hands.
I have pretty small hands.
Sometimes you have to get help from someone else to get them off though. I mean,
No, you
you've got
don't.
it, like all over.
You
Can't
don't.
touch your wrist without getting it on.
Yeah, you should not have to. Okay. Yeah. Be aware of blood and body fluids. That's what you're actually looking for. Hence the gloves. Blood and body fluids. If you have someone who is, is MRSA or C. diff, then you certainly don gloves. If you have someone who is, is actively bleeding, then you don gloves.
Mm-hmm.
If you have someone who is on an IV, then you don gloves. Why? Why the IV?
Because they got a hole in them with a needle in there.
Bodily fluid.
Yeah, it could leak.
That's basically what it is. It's not so much that they have a needle in their arm. It's the fact that the needle can shift and then there's blood out. Or if you have a patient who is positive for shingles or scabies, then you have gloves. Now, TB. What's the difference between all of the ones that we've mentioned and TB?
TB, you can get through the airborne.
That's airborne. So, if you have someone who is active TB, now there's a difference. If you have someone who is active TB, they should be in the department to begin with. But if they need to be treated, then what do you add to the gloves? What kind of mask?
N95?
N95 minimum. What else what other thing can you use apart from the N95?
Maybe
You've seen
a
them
face
being
shield?
The respirator type masks, not the N95.
They got the
masks,
filters in them,
actual
don't they?
respirator type masks. That's what they're using a lot in, especially in ICU with COVID. COVID is not airborne, but it's communicable. So what's so special about communicable disease? What does the physician have to do if he finds someone, whether they're cancer patients or not? If you go to a physician and he finds out you have TB or any other communicable disease, what does he have to do?
Notify the health department.
Well, not quarantine, no. Notify the health department, because those communicable diseases are tracked. That's how you know if there's an outbreak of measles or mumps or chickenpox or whatever it happens to be in the area, because those are tracked. Same as COVID is, same as TB is. That's why you have to have a TB test. Who here is positive? Who here came up positive?
For TB?
No.
Oh.
I came up positive on a MAN2 test though.
Oh, for what?
For what? My MAN2 test, which is the
bubble.
The bubble,
thingy.
you know, what is the negative test for, what happens? You get your little MAN2 test, which is the test that you stick things into your arm. What is the negative effect?
No change.
No change. What's the positive effect?
Your skin bubble.
You get a bubble. I don't get MAN2 tests anymore. I have to go for a chest x-ray every couple of years because I always come up positive. There's two reasons for that. Actually, one reason for that is that I grew up in farm country and I drank milk straight from the cow. It wasn't pasteurized, it wasn't, literally, you know the churns, oh you don't know, you're too young for the churns. The milk churns, we used to go to the farm, literally, I mean I'm aging myself, but we used to go to the farm with milk bottles and they'd get a big ladle and take it out of the churn and put it into the milk and off we go.
Probably some good stuff.
Huh?
Probably some good stuff.
Oh, it was wonderful.
I bet it
The cream
tastes
was
super.
about knee thick on it. It was wonderful.
What kind of milk do you drink now, though?
Whole milk.
Do you drink whole milk?
Actually, no, I drink 2%.
No, she drinks heavy cream, actually, yeah.
But the milk bottle was a pint. And it had about this much cream on top.
Oh my gosh.
It was wonderful. My brother and I used to fight over the cream for our cereal in the morning. And
now has he been tested? Does he come back positive? Do you know?
oh yeah, he comes back positive every time. So the thing about it is if you ever come back positive, you shouldn't get another MAN2 test. You should just tell them and explain why, obviously. And because I didn't realize that I was positive, that I didn't think anything about it until I started training. And we had a patient who was, as it turned out, active TB that nobody knew about. And we all had to get tested. And they panicked when I came up positive. And then they did the chest x-ray and I was fine. And then the doctor said, okay, you know, what happened? So I explained it and I said, okay, fine, go away. You'll always come up positive.
That's crazy.
So yeah, milk straight from the cow, eggs. We used to go up and get eggs from the farm and you'd have to clean them off because they were straight out of the chicken.
I used to eat farm fresh eggs. I mean, those are the best eggs when they're fresh. They taste the best when they're farm fresh.
Oh yeah, because they're orange. They're orange.
Oh yeah, the yolk is that deep orange. It tastes.
Yeah. Anyway, that's beside the point.
I eat eggs
So,
every
TB tests, you have to have them, just in case you have a patient who is active TB. You can be TB but not active. And active means that you're capable of spreading it, right?
I wonder what lungs look like when it's active. Like what do they expect to see on the X-ray? Chest
I don't have, I'll find one out for you. I'll find one for you.
I think I've seen it like in the anatomy class.
Yeah, yeah. Yeah, they are very interesting to look at. But anyway, so what I thought we'd do today, the rest of the time, is that I would show you some stuff that we'll be talking about for the next little while. So, this, ladies and gentlemen, it's what we call a wing board.
Oh.
And what we do with that is, can I have a volunteer? Please. Okay. Sit about there.
Oh.
That's okay. That's okay. No, it's all right. Okay. Swing your legs round and lie down. No, your legs round that way.
That way.
This is a head base. Okay, down a bit. Okay, that's fine, that's fine, that's fine. Okay. So basically the patient would lie like that. Okay, everybody see that?
Yeah.
And the idea is that if you're treating the chest, you want the arms out of the way, right? Because you don't want to treat the arms. So, give me your arms. Go down. Let them go. Relax. And there. Okay. So this gives you some support on the arms. Okay, and oh, hang on, don't clench them. Hang on a minute.
Can you?
Okay.
A little narrow.
There, okay. Sorry?
I see the arm goes up and down, but for people who have short arms, does it slide closer to the head and farther away from
Yeah.
the head? Oh, okay.
Yeah, I just moved it.
Okay.
And the reason why we're doing this is normally you would probably do about that. Don't clench it, just relax with it, okay? That's okay. And the reason why you can't sort of bring them out like this is you have to get them through the CT tunnel. So you want them out of the way here and out of the way here so that you're good here, okay? And when we start doing things like vac locks and masks, you'll see how this actually comes into use. Okay, you can let go now. Put your arms down and sit up. I don't know why this is moving. Okay. And down. I don't know why this is moving. Okay.
Pretty spooky.
So.
I did it.
Good job, Steven.
Yeah, I slid right off that thing.
This is a fairly long, high one. So if you had a patient who were treating, say, the head, and he can't get his head back too far, then we'd use this. There's all sorts of different ones. So this is the same angle as this, only it's lower. So for the normal patient, for a patient that is in a neutral position, we would use this one. For someone who you need to sort of put their head back a little bit, then we'd use this one. You can see the neck shift this way. Okay?
So the high part would go up under their neck and the
Yeah,
low part would
that's
go
right,
under
would be
their
the head. If you wanted the patient to have his neck hyperextended, if we are treating down here somewhere, we would treat something like this. It would be really deep. Should be another one. Okay, doesn't matter. So we'll we do this. And then we have the masks. And these are the masks as you would find them in the department. You've seen them molded. Each one of you will actually get to use them, get to make a mask. You will also get to wear a mask, have a mask made. The reason behind that, it's not just because I'm a sadist, is that if a patient asks you, what does it feel like to have a mask made? And you haven't had one made, that's not good, right? Well, I don't know, I've never had one made. But if you can tell them what it feels like, then it can put their mind at rest, maybe. Basically what the normal person feels like is that it's warm, feels like a facial. For the ladies, it feels like a facial. All they have to do is relax, close their eyes, and imagine themselves in Hawaii or somewhere.
Do men have to shave off their beard? For
No.
the mask? No?
No. No, they don't. The one thing that when we start doing this, and we're not going to start doing it now, is that we will ask the ladies and gentlemen, if they have them, to take their earrings out, because it can pull on their earrings. And depending on what their hair is like, we may have to reposition their hair. Okay? If your hair is in a ponytail, for example, then we will put the ponytail underneath the shoulders. That's what we normally do. If it's somebody like one of the girls I had in one of the classes who had beautiful hair, but she had it in dreadlocks, it was really difficult because there was a lot of poof, and we had to just put it underneath her shoulders, and it was really difficult. The one thing that you'll find is that if you make it that way, you have to remember that way. So you write in the setup, what they call the setup instructions, that go from CT to the treatment machine, that patient's hair was in a ponytail and underneath her back. So that means that you're lying on your ponytail, because it could be that we put it up above the head and make the mask that way. And that can alter the fit. So that's something that we need to look out for.
So if the patient had her hair like this, we'd have to have her hair like this for treatment too?
If you have whatever way you have your hair when you do the mask, you have to have your hair that way. Okay?
Yeah.
Having it up in a bun like that probably is not the best thing to do. But having it back in a ponytail, if it's long enough to do that, then that's much better.
What about just like taking it out? Would that be like worse? If
Sorry?
you just took the ponytail out completely, would that be worse?
It depends on what you have
for hair
on your hair. If you have the ponytail in a fancy clasp or just in a scrunchie or something like that, you can probably push it down. But if you feel better to let it go loose, and we can put the loose hair underneath underneath your back. It very much depends on the type of hair you have also.
Mm-hmm.
Are the masks one size fits all?
What?
Are the masks one size fits all, or are they different widths for different size heads?
No. These will fit any size head because they stretch.
What if the patient's like their hair starts falling out? You have to do another
mask? That depends on the physician, and it depends on what we're treating. If we're treating, say, the head and neck, the neck, for example, and the patient is on chemo, which is making her hair fall out, then as long as the mask fits at the forehead, the nose, and the chin, it's okay, because we're treating down here. Now, if we were treating up here, then we may have to make a new mask. So the other thing that we usually use is, these are backlocks. So what they do, and I'll show you a little video on things like that. So what they do is we put them on here. We take the air, we put air in so that they're nice and malleable. And then the patient lies down, and let me do that now. Okay. 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 I need somebody with strong thumbs. Come on in.
I can't do this.
Oh, it's okay, got it.
Easy game. We
Got
got
it. So, what I'm going to do is, this is a connector, this is a pump, just an air pump. And it says air in, air out. So, I'm going to, here we go. This will make a noise. Okay.
Looks like a luxurious dog bed.
Okay, so this is how the back lock looks. I wish I could figure out how to
Lock the table.
lock the table. I know, because it's not plugged in. I
It's an
think.
electric table? It plugs in.
There we go.
I love technology.
Uh-huh. So what will happen here is the patient would lie down, and we would take the air out, and it would mold itself, or we would mold it to the patient. And that would give us an immobilization device. So, let me take this out, and I'll leave this here. And we will, and we've got several of them, so we can do some of that in a little bit. So I'm going to show you another video here. So this has no sound. So you see this patient is going through, this is a CT. So the patient has a wing board underneath this. This is a back lock, so she's now taking the air out, and she's about to make sure that it's shaped over the patient's.
It's like getting tucked in a little.
Yeah,
similar.
basically. And once they're finished, there's only one way that the patient will lie down on that and be comfortable. So now she's putting her into the CT. Obviously, the people that we're seeing on these videos are staff members, so they're not stripped.
What is she sticking on her?
So these are little BBs that are radiolucent so that they can be seen on the CT. again, these would be put on the skin. And we would also, you see the red line on the back lock? You would put masking tape down on the back lock and put marks on so that you can align it with the patient. So now she's finished. And she's taking her out. And when you're doing this, you have to make sure that the bed is far enough out that you're not going to collide with the CT. So now, when she gets up, that is the back lock, and it will stay like that for the, that's just the tattoo that she's doing. It's just to show you what the tattoo, what the size of the tattoo is.
So where do they store all of these backlocks?
Okay,
You're
so
saying they
like
use the
that
same one?
is that
Say again?
Where do they store all of those backlogs? If you're using that for the entirety of the treatment?
Yes.
So do they have a storage place for and patient ID?
They're actually they're usually kept in the treatment room, and they are all marked with patient's ID numbers or ID, depending on what the protocol is. Some patients, some departments will have them with the first name and the last initial, or their patient number, or just their initials, depending on what, and they're all actually hung up.
So how many would you have at a time?
35,
Yeah.
depending on how many patients you have and what the patients are. Anybody who is a curative treatment for anything of the pelvis, abdomen, chest, extremities would most likely have a backlog.
And then what happens to them after their treatment's done?
They're cleaned and reused. That's not what I want. Let's go away. Okay, so there's another one that I want to show you. Oh, go away, not that one. There's another one I want to show you, which is Civco. That one. Minimize that. And then minimize that. Go here. And I will be sending all these to the Canvas. I did send the stuff yesterday and also the syllabi. Did everybody get them? Or have you looked at it yet?
Oh, normally I get notified, but I didn't get notified.
Huh?
Yeah, my notifications
Normally I just
are
get
not going
notified. Yeah.
Okay.
I'll have to check.
No, that's fine.
I think they did software changes or something. Or even my set. Now, these are radiation therapists that are tucking them in and backlocking them in and all that stuff. So we do CT scans ourselves.
Yes.
Mobilization and positioning. Patient setup for pelvic radiotherapy treatment presents many unique challenges. Due to the shape and dynamics of the site, clinicians often encounter difficulties with both interfraction and intrafraction errors. Externally, skin markings are often distorted by various positioning devices, which challenges the reproducibility of intrafraction setup. Internally, the tumor location is often affected by intrafraction organ motion. In addition, enveloping immobilization of the pelvic region can sometimes result in an increased bolus effect, as well as further distortion of skin markings. Rotational errors must be addressed and are not easily corrected on standard treatment tables. Effective pelvic positioning and immobilization devices should improve both inter- and intrafractional accuracy. add little to no additional attenuation or bolus, and provide an enhanced level of comfort for the patient. We'll begin with a few basic instructions and then demonstrate the carbon fiber belly board, hip fix system, Compafix, and back block cushions. Sitco hip and pelvic positioning products are designed to handle a wide variety
You
of patients
may or may
and
not
therapeutic
see
situations.
any of
And there are
these
some
in
basic
the
instructions
departments.
that apply to all
Back block you'll
products.
always see.
In all cases, Sitco products should only be used by order of a physician. All disposable products, including thermoplastics, are intended for one patient only and should not be reused for additional patients. Reusable products should be appropriately sanitized. When treating certain pelvic and colorectal cases, there is a need to avoid irradiation of the small bowel. To achieve this, many departments use a belly board with an abdominal aperture. By positioning the patient's abdomen within the aperture while simultaneously elevating the pelvis, the small bowel is displaced within the cutout, essentially falling out of the field for both planning and treatment purposes. The Sitco carbon fiber belly board is designed to reduce the irradiated small bowel volume of the
No, it's support, that was just a diagram, this is supported.
and reproducibility. This indexable positioning device features an abdominal aperture for capture and containment of the small bowel. For enhanced repositioning, prominent lateral rulers provide an external setup reference point, while an embedded fiducial crosshair array assists in additional repositioning for IGRT. To begin setup, place the carbon fiber belly board onto the table, securing it into position via the 2-pin lock bar. An additional slide guide lock bar may be used for added stability.
That makes sure that it's not moving anywhere.
Positioning the patient slightly superior to the intended treatment position location on the board. Now, begin sliding the patient down the board in a cranial-caudal direction until the patient's abdomen has sufficiently entered the aperture and the pubic symphysis is resting upon the belly board's pelvic platform. Center the patient. This movement results in the small bowel being compressed and rolled forward into the abdominal aperture.
Obviously, the patient would have no shorts on. But this is because it is,
Thereby
just a
dropping
demonstration.
significantly out of the field. An optional prone thorax support cushion can be used to elevate the patient's head and thorax region, helping minimize undesirable chest compression of large-chested patients. To use the prone thorax support, simply position the cushion within the border of the belly board's upper cutout, utilizing the Velcro pads to secure it in place. Once the setup position has been accepted, apply reference setup marks as needed, taking additional note of the patient's location relative to the lateral laser line on the belly board's lateral rulers. The carbon fiber belly board is an efficient, reproducible, and ergonomic prone positioning device that helps aid in reducing the irradiated volume of the small bowel. Sitco's IGRT compatible hip fix system provides enhanced immobilization for the hip and pelvic region. While the loose skin surface of many pelvic patients may be unreliable for setup verification, image guidance using bone and soft tissue has proven to be a trustworthy source for positioning correction and accurate tumor targeting. However, once the IGRT setup corrections have been made, there still remains a need to ensure that the patient does not move during the treatment delivery. To assure adequate reduction of this intrafractional movement, there must be sufficient immobilization of the patient. For such fixation, a thermoplastic solution is often used, designed for setup in either the prone or supine position. The hip fix consists of an indexable base plate with a cutout treatment window and utilizes a single thermoplastic sheet with side docking handles for fixation. These sheets are available in two thicknesses, 2.4 and 3.2 millimeters, and also in perforated solid or IMRT reinforced patterns. In addition, the hip fix can be integrated with the back block system to provide both repositioning and immobilization benefits. To begin setup with the hip fix, position the 2-pin lock bar onto the table and index the hip fix board onto the 2-pin lock bar. Next, position the patient onto the board. Do an initial visual check to make sure the patient is centered
I have used this. It is not easy to do. It is very uncomfortable for the patient, so just so that you're aware.
And not rotated on the board and adjust the patient as needed. Then shift the couch top so that the lateral lasers land on a predetermined scale mark on the side of the hip fix board. Marker 15 is often ideal. Mark the patient to the lateral midline lasers. These marks will now serve as daily repositioning marks for correctly placing the patient onto the base plate. Once positioning marks have been applied,
It does look uncomfortable.
insert the thermoplastic sheet into the water bath.
It does look uncomfortable.
Yeah,
it
is.
Remove the softened thermoplastic from the water bath and swiftly dab with the towel. For this presentation, we will be using an IMRT reinforced 3.2 millimeter thermoplastic sheet with disposable handles. Working with 2 people, hold the handles and pre-stretch the sheet above the patient. Slowly pull the sheet down over the patient and lock each handle onto the hip fix base plate in the docking points nearest the patient. Gently stretch the rear portion of the sheet downward, locking the groin piece between the patient's thighs. Continue to mold the thermoplastic sheet around the patient's contours to ensure a snug fit. To avoid shrinkage, allow the thermoplastic to cool completely before proceeding. Next, apply initial treatment marks to the cooled and hardened cast. Additional reference alignment marks, such as handle and row positions, can be written on the hip fix setup sheet. Begin the scan and mark the cast, not the patient, with the final isocenter alignment marks. In the treatment room, begin by placing the 2-pin indexing bar onto the appropriate position on the table, and place the hip fix base plate over the 2-pin bar. Next, position the patient onto the hip fix board and drive the table forward so that the lateral lasers land on the base plate's predetermined scale marked specific to the patient. Utilizing the patient's skin positioning marks, align the patient to the lateral and midline lasers, thereby ensuring the same position of the patient relative to the base plate as occurred in their CT sim. Once properly aligned, bring the preformed hip fix thermoplastic cast down and over the patient, and dock into notated docking points on the base plate. At this point, the thermoplastic cast should be serving primarily as an immobilization drape. Once secured, shift the patient via the table to the treatment marks that were placed on the cast. Image as needed, corrective warranted, and treat. To enhance the repositioning characteristics of the hip fix system, consider integrating the hip fix back lock cushion with the hip fix base plate. To simplify workflow and avoid rotational errors, many departments favor using a simple wedge system placed directly under the patient's knees and feet for supine pelvic setups. The CombiFix is an efficient modular wedge-based positioning device for supine pelvic setups. CombiFix's indexable base accommodates Civco's Knee Fix 2 and Feet Fix 2 cushions, allowing for repeatable custom positioning of the patient's lower extremities. Both the Knee Fix 2 and Feet Fix 2 can be indexed independently. To accommodate various sized patients, the Feet Fix couch support can be placed at various points along the CombiFix frame, and its adjustable tilting feature provides a natural angle for enhanced patient comfort. The removable support structure allows the department to use the Feet Fix couch support as either an integrated piece or as a standalone positioner. 5-centimeter elevation blocks provide custom elevation for the Knee Fix cushion, allowing the clinician to create a natural, ideal relation between feet and legs. Shoulder retractors are also available for use with the CombiFix. To begin setup with the CombiFix, dock the 2-pin lock bar and the 2-pin slide guide lock bar onto the table, and index the CombiFix frame to the lock bars. Next, place the Feet Fix couch support onto the most superior point of the CombiFix frame, and insert Feet Fix 2 cushion snugly into place. Place the Knee Fix 2 cushion into the cushion guides. Begin by positioning the patient's knees. Next, adjust the placement of the Feet Fix couch support along the longitudinal plane of the CombiFix frame, ensuring that the docking location results in the patient's knee resting fully upon the Knee Fix cushion. If the Feet Fix support structure is at the most superior point on the frame, and the knee is still not resting fully on the knee fixed cushion, utilize the 5 centimeter elevation blocks to help shorten the distance between the knee and heel, ensuring a proper fit. Then, adjust the tilt on the feet-fixed support structure until the desired natural angulation has been achieved. Record all settings on the CombiFix setup sheet. Continue with simulation and treatment as required. The CombiFix system can also be used as a shoulder retractor for head and neck treatments. To utilize this feature, first select the appropriate length shoulder retractor strap. 2 lengths are available. Have the patient reach through the padded hand grips and securely grip the strap. Next, pull the strap inferior until optimal shoulder retraction has been reached, and insert the docking pin into the corresponding docking hole in the foot support structure. Repeat procedure for the other side. Record.
Are we doing this to each other?
No.
My body might need that.
No, that would be too much like fun. What do you think, what do you think we do that for?
Pulling the shoulders down with
Yeah.
the docking pins?
Pull the shoulder.
To do
Give more clearance for head and neck, I would assume.
Yeah, so, basically that's just a way of pushing the shoulders down, or pulling the shoulders down. And that's one, you may see that done, not necessarily that particular type, but the shoulder pulls, which is what they're called, are used quite often.
If you have someone that has like a bad shoulder, do you have alternatives? Like if someone had surgery on their shoulder, or they
It
had
depends
arthritis?
entirely on what area we're treating. If you're treating down here and close to the shoulder, then you have to pull the shoulders down. And the alternative would be to use a longer mask, and that would push the shoulders down. But if the shoulders have to get out of the way, they have to get out of the way.
Approach to pelvic setup and treatment. All hip and pelvic setups require accurate repositioning and secure, comfortable immobilization. As no two bodies are the same, there's often a need for customizable setup devices that can conform to each patient's unique shape. Such a custom fit results in increased repositioning and enhanced comfort for the patient. Sitco's back-block cushions are an efficient, reusable repositioning system for hip and pelvic radiation therapy. Back-block cushions come in a variety of shapes and sizes designed to accommodate various body types. Each cushion contains tiny polystyrene beads that compress together to form a custom contour of the patient when air is evacuated out of the cushion. Back-block cushions have a robust exterior that is easy to clean. The cushions are available in either puncture-resistant polyurethane or durable nylon. Some nylon cushions also feature an indexing back compatible with Sitco's 2-pin indexing system. To begin setup, select the proper size and shape cushion for the particular patient setup. For this setup, we have chosen a 75 by 120 centimeter rectangular pelvic back block cushion. If the back block cushion is indexable, begin by indexing the 2-pin lock bar and the 2-pin slide guide lock bar to the table, and secure the cushion to the bar via the indexing batten attached to the cushion. The 2-pin slide guide lock bar is essential for stability and also to accommodate the constriction of the back lock cushion during forming. If the back lock cushion is not indexable, position the cushion square with the couch top. Next, pre-position the beads within the cushion, anticipating areas where more beads may be needed for necessary support, and removing beads from areas where attenuation could be a concern. When initially forming the cushion, be mindful of clearance considerations, such as the CT or the Lennox gantry. Then have the patient carefully enter into the cushion. Evacuate some of the air out of the cushion, stopping at the point where the cushion is still malleable, just able to hold shape and form. Perform final adjustments at this stage, creating as much definition as possible and being mindful to ensure that the patient is not rotated. Finally, evacuate the remaining air out of the cushion. Continue until the cushion is rigid and has ceased to constrict any longer. Sitco's back-block cushions feature a self-sealing valve that ensures an airtight seal when the vacuum hose is detached. A valve sealing cap ensures that the valve remains safe from an accidental air intake. If the scalp film or fluoral necessitates repositioning the patient, simply add air back into the cushion and perform the revisions. When satisfied, re-evacuate the air from the cushion until rigidity is achieved. Backlock cushions are reusable. Therefore, it is recommended that positioning and treatment marks never be placed permanently on the cushion. Instead, use paper or masking tape to draw positioning marks onto the cushion. Patient ID can be attached to the cushion accordingly, or via detachable tags designed specifically for backlock use. Due to necessary sanitary and safety considerations, backlock cushions should not be stored on top of each other while in use. Specific backlock storage systems, such as shelves or racks, should be used for storage. Each backlock cushion features a reinforced corner designed for hanging the cushion. Once the treatment cycle with the backlock cushion has been completed, the cushion should be given a final, thorough cleaning. The cushion is now ready for the next patient treatment cycle. During this presentation, we've demonstrated 4 Sidco immobilization and positioning options for the hip and pelvic region. The carbon fiber belly board, hip fix system, CombiFix.
Questions on that?
When did we start using the Vaclock bags? Like, when did that come about? Like,
About 20 years ago?
20 years ago. What did we do before that? Because those just seem so useful with the rigidity once the air is out.
Yeah, the problem with the early ones is they were very easy to puncture. And if they were punctured, then you couldn't use them anymore. And the patient would have to go back, be repositioned, re-CT'd, replanned, etc. What we did before them was that we positioned the patients straight and level, used a device to keep their feet steady in one position, and made sure that the patient was straight.
Do we normally have our own CT, or do we have to go take them to CT, depending on where we are?
These days, most departments have their own CT. And they are not used for anything else other than
our needs.
The radiation therapy needs, yeah. One of the departments I worked in, that was in Louisville, we had a brand new department that we moved into, and we had a brand new CT, beautiful CT, and we were attached to hospital. And our radiologists in the hospital said, "Oh, good, we have another CT to use," and the doc said, "No. This is purely for radiation therapy. We are not licensed to do diagnostic CTs. We are not trained to do diagnostic CTs." So in our department, the therapists do the CTs. We do not do diagnostic CTs at all. There are some small centers that still rely on either imaging centers or hospitals to do their CTs, which means that all of the backlocks, masks, whatever it happens to be, plus a patient, plus a member of staff, have to go over to the hospital to make sure that this stuff is done correctly. And the CTs in most of the hospitals have a curved bed. So they have to have a special flat bed for us. So it's a bit of a bind for both people, because if you're trying to get time in an X-ray department CT, you have to take the times that it's available. The patient has to come when the hospital can do them, which is another So you have to have a member of staff there. The belly boards are really good. That one was a high-tech one. They come in all shapes and sizes. Normally the normal ones are about 4 inches thick rubber, and they place on the top of the bed, and the patient has to climb up and get on, obviously. It can be a bit of a hassle if you have somebody who is not in the best shape trying to get them from. So we can use the back locks in pelvis, abdomen, chest, basically anything. Oops, right, let's do this again. Here, so let's do the head and neck. Oh, got it.
Solutions offers a wide variety of head and neck treatment products, allowing customers